Hello and welcome. We have a very important show for you tonight. We're talking about Parkinson's disease, but more specifically, we're talking about the non-motor symptoms that accompany Parkinson's. And I've learned that almost all Parkinson's patients have many of these symptoms. Not all, but many. My guest tonight is Okeanis Vaou. She is a physician. She's rather new in Minnesota, so I'm delighted to meet her and to introduce you to her. She is a movement disorder specialist and a sleep disorder specialist. She works at the Noran Neuruological Clinic here in Minneapolis, and she is the medical director of the American Parkinson's Disease Association, the Minnesota chapter. Mm-hmm. So you've become very busy since moving here, and also have two little babies and a busy life.
It's a very busy life, that's true.
Well, the number of people who have Parkinson's is significant. The number of people who have the non-motor symptoms is almost as significant, correct?
Mm-hmm. That's very correct. And of course, those two go together. But most people tend to focus more on the motor movements and symptoms. However, the non-motor symptoms are as important because they do, they're very debilitating to the patient and also need treatment as well.
And they affect your life every day, most of them, don't they?
That's correct. Mm-hmm.
On a daily
Mm-hmm.
basis.
Mm-hmm.
There are many of the non-motor symptoms, and as you listen, you'll know what we mean by non-motor symptoms. We probably won't cover all of them, but we'll cover most of them. So let's start out with one that you said is very common for many people, the sleep disorder symptom of having sleep problems.
Mm-hmm. So sleep disorders in the Parkinson's disease population, we see it in probably 60 to 90%, so it's pretty prevalent. Now, they don't all have the same different disorders, but a list of them is the REM behavior disorder, which basically is when people in their dream stage, REM stage, they don't have their muscles relax, which is something that happens to people who don't have the disease. Due to this, the patients start acting out their dreams, they kick, they yell, they talk, and is potentially very important and very serious condition because it has a high risk of injury, both for the patient, also for the bed partner.
I hadn't thought of the patient being at risk, but the bed partner
as well.
Certainly. Mm-hmm. But the patient at risk because he or she could...
They can fall out of bed.
Okay.
They can fracture their arms at the bedside table.
Slapping their arm against the
Correct.
Headboard or whatever.
Mm-hmm.
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 That makes sense.
I have patients that have fractured hips just because they fell out of bed. Mm-hmm. So it's something that we should take into consideration.
So they are having REM sleep and acting it out.
Right, because they don't have the muscle relaxation, which happens normally in REM sleep. And what they're seeing in their dreams, they're trying to act it out in bed. Mm-hmm. So it's pretty dangerous sometimes.
So it means their sleep is probably disturbed too.
Correct.
Not as deep.
Mm-hmm. Mm-hmm. And that's another issue with patients with Parkinson's disease, that they have an interrupted sleep and what we call a fragmented sleep. Not just because of REM behavior disorder, but because they wake up very frequently in the middle of the night to urinate because they have muscle stiffness, they can't turn over in bed, muscle cramping is very common, restless leg syndrome, obstructive sleep apnea, the list goes on. Mm-hmm. So their sleep is interrupted, and that in itself also leads to excessive daytime sleepiness.
Well, it would, wouldn't it? I mean, if you're not getting enough sleep at night.
Mm-hmm. Yeah. So very commonly, again, in Parkinson patients, we find that they're very sleepy during the day. In very severe cases, they tend to sleep during the day and are awake at night. Another cause for the daytime sleepiness is the medication themselves. So, for example, the dopamine agonist, as a side effect, they have sedation and sleepiness. So, and we also think that the disease itself, Parkinson itself, can cause some sleepiness as well during the day.
And as I was learning more about this, a lot of the medications are at fault in the sense of causing a lot of these symptoms we'll be talking about. So it's kind of a catch-22, isn't it, for the patients? I mean, you need the medication.
Yes. So sometimes we have to decrease the medications because of the side effects and add some others that may not have the same side effects. So it's very complicated to treat a patient with Parkinson's, especially if it's advanced Parkinson's disease, where all these non-motor symptoms are more prevalent.
One of the things that you and I were just talking about is how some of the non-motor symptoms can precede the diagnosis by many, many years, which is going to, I'm sure, cause viewers to pay attention and listen. But one of the ones that is an early symptom is the sleep problem, the RBD.
So REM behavior disorder, we've seen that it predates the diagnosis of the diagnosis of Parkinson's disease by an average of 12 years. So that's very important to know. Of course, we can't say that whoever has REM behavior disorder will develop Parkinson's disease because it's not specific to Parkinson's disease. We see it in other conditions, Lewy body dementia. We can see it in Alzheimer's disease and atypical Parkinsonism, so in other conditions as well. But it's rather interesting. It is a warning, such
symptom,
as
isn't it?
such as other symptoms, lack of or decrease of smell, that can predate the diagnosis by about 4 to 5 years.
And do you mean, Dr. Vaou, a complete lack of smell where you really lose?
Start losing the smell, what we call hyposmia, so some lack of decrease in smell and eventually loss of smell.
Which of course affects appetite and all kinds of things, but that can precede the diagnosis also by, you said 4 to 5 years?
4 to 5 years. And now we're looking into utilizing this in early diagnosis maybe of Parkinson, or using it as a marker for Parkinson's disease.
And why is it important to find these things out early?
That's a very good question. So first of all, for research and into developing medication that would cure Parkinson's disease or delay the progression of the disease.
Okay, so 2 major reasons.
And that's what is the most important research right now in Parkinson's disease.
Because right now there is no cure.
Correct. Only symptomatic treatment.
Just briefly, the other 2 common symptoms that can precede diagnosis, constipation, I believe.
Constipation is one, and also depression and anxiety. Constipation is probably the we see it usually up to 18 years before diagnosis.
Wow. But that could go along with a lot of other problems.
Exactly. So
and depression.
And
certainly.
depression, the same thing, and anxiety, the same thing.
What have I learned? About 1 out of 5 people deal with clinical depression sometime in their lives, and they're not all going to get Parkinson's.
Correct.
But
most
again,
of them will not.
Most will not.
Yeah.
But again, it's important to pay attention, be in good communication with your physician, right? Okay, let's talk about pain. That's another non-motor symptom of Parkinson's.
Exactly, and that's very important, and I would like to increase awareness about pain because many patients don't realize that pain is part of Parkinson's disease. It's another symptom. We've seen that perhaps half of patients with Parkinson's disease deal with pain, sometimes even before the diagnosis of pain, of Parkinson's disease. They don't know where it's coming from.
So they might suspect arthritis.
Correct. And they go to different doctors trying to find out where their shoulder pain is from, for example. Usually it affects the more involved side.
So it might be pain just on one side of the body. That would be a clue, wouldn't it, for you as a physician?
Yeah, but again, you can't tell. You have to
so
have the other
common.
symptoms in order to diagnose Parkinson's disease. So it's very complicated, but it's also interesting that half of the patients who have pain due to Parkinson's disease do not report it to their physicians because they don't think it's related to Parkinson's disease. So then those patients are not treated.
And treatment for the pain, is it the traditional things we think about that are used
Very good
for
question.
other conditions?
It depends on what the pain is from. So yes and no. So yes, we do use the usual management that we, for any type of pain. If it's a musculoskeletal pain, which is the most common in Parkinson's disease, and it could be due to the stooped posture that they have. They have put a strain to their back. Other types of pain that we see could be due to muscle spasms and contractions because of lack of dopamine or their medication is wearing off, so then we adjust the medication. Other types of pain is what we call the central pain in Parkinson's disease, which is a very hard type of pain to describe, for the patient to describe, which we feel is part of the disease process itself.
How would you define it?
It's very hard to, like I said, to localize. The patients call it a burning, generalized, non-specific pain. It's very different. It's not like the shoulder pain that they come in for. So they should also be aware that this could be part of Parkinson's disease. And it's also very interesting that this type of pain improves with dopaminergic medication, the medication the patients take for Parkinson's disease.
And you may want to say just a couple things about the dopamine. It's the oldest, isn't it? Medication and
the best.
The go-to one, right?
The oldest and the best, yeah. So we have a lot of medication right now that we use currently for Parkinson's disease, and there's also many others in development and trying to get approved for FDA. So yes, we have levodopa, carbidopa, levodopa, the oldest one and the best, like you said. Dopamine agonists, then there are the MAOB inhibitors, and some others that are not so frequently used. So we have a pretty a big palette of medications to choose from, but even so, sometimes that's not enough.
And as we know, learning from Michael J. Fox about Parkinson's, you need to increase your dosage, don't you, as your disease progresses?
And many patients tend to think that it's because the medication are no longer working or their bodies get used to the medication. Actually, that's not true. It's mostly because the disease is progressing, and therefore we need to give more medication.
That makes sense.
More dopamine.
So sleep disorders, pain. Another common symptom, non-motor-wise, is urinary problem, urgency.
Which falls into the category of autonomic disorders. And many patients have an urgency to urinate. That's caused because the bladder is contracting very frequently, more frequently than normal. So that's what makes them have that symptom.
So that just adds complications to their life if they're going out and,
And also during sleep, because they have to wake up and
course.
get out of the bed, go to the bathroom, and that happens probably on average 2 or 3 or even more times during the night.
And would that be worse for men than women? We hear men over 60 talking about this as a problem kind of in general.
Right, but it's due to other disorders, but not for Parkinson. It's the same in men and women.
Both men and women deal with this.
It's just that we see it more frequently in men because Parkinson's disease is more frequent in men.
lightheadedness, another tough symptom to deal with on a daily basis. How common is that?
Again, that's a autonomic nervous system disorder. The cause for that is what we call orthostatic blood pressure. Orthostatic hypotension. So basically, the blood pressure tends to drop when you stand up, and that's why patients get lightheaded.
So a real low resting blood pressure too?
No, well, resting doesn't necessarily have to be low. It's when you transition from a sitting to a standing position, that's when the blood pressure drops. It can happen because of Parkinson's disease. It can also happen because of the medication as a side effect.
And how common is this as a symptom?
It usually affects around 30 to 40% of the patients, depending on what, and also depending on what stage of the disease they're at. So the more advanced, the more common it is.
I was reading an article the other day, and I think you were quoted about the importance of exercise for people with PD, Parkinson's disease, and how that can really ensure that you will live longer in a healthier way. But the lightheadedness, I'm
doesn't
thinking,
help.
Oh, that would make it tough for exercise.
Well, yes and no. It is, of course, it's very hard to exercise if your blood pressure is low. However, exercise helps with that as well, because
so it can counteract that?
It strengthens the calf muscles, which act as compression stockings, pumping the blood higher to the brain, to the heart and brain, so bringing the blood pressure higher and preventing it from dropping once you stand up. So yes, exercise is helpful in Parkinson's disease in so many ways. In balance, in strength, it has also been found that it can delay the process of the disease. So
that's some good news here.
Very good news.
I know a lot of these symptoms sound really problematic, and it's a tough disease.
Plus, it improves sleep. It improves depression.
Yes.
So what medication can do all that?
Right. So it's kind of, if there is a magic pill here, it's probably exercise. Huh?
I believe it is.
Now, depression, you know, we've talked on this show about many chronic diseases, and I think depression probably is the common cousin for all of them. But it's particularly important to Parkinson's because it can predate the diagnosis.
Predate the diagnosis. It's also very important because it decreases, limits the quality of life for the patient. Patients are not as motivated when they're depressed, so they don't exercise.
Right.
Exactly.
That'd be one.
It worsens their sleep at night, so that makes them more sleepy during the day. So everything is connected. And
it would affect their caregivers, their relationships with their family?
Absolutely. And it also comes with anxiety as well.
When you say that, do you mean that if you're depressed and have Parkinson's, you'll probably also be dealing with anxiety?
To some extent, yes. And many patients are very anxious on how they perform in public, with their relatives, with close friends, and they seem to become more anxious as their medication tends to wear off. So patients with fluctuations, motor fluctuations throughout the day tend to be more anxious when they feel that their tremor is coming out or they're more stiff. And that's something that we also need to look at, kind of optimize their the Parkinson medication treatment in order to improve anxiety.
Would you say that depression and anxiety go hand in hand for most people?
Not always.
Okay.
No.
So you could be depressed and not have the anxiety, or have the anxiety and not the depression.
And in Parkinson patients, we treat both conditions with antidepressants, and it seems to help.
Is there a common problem, Dr. Vaou, with interactions with the Parkinson's meds and the antidepressants? Because they're kind of tricky, even given, you know, treating depression per se alone.
That's a very good question. That's a question actually that I get from pharmacies quite a bit. There is a concern about the MAO-B inhibitors and the SSRIs, which are the antidepressants, there is no problem. There's no interaction between the two. But I do get that question a lot from pharmacies.
So that's another good news thing. You can be treated for both Parkinson's and depression and not worry that the medications are canceling each other out or causing other problems. In terms of depression, do you see it usually getting worse and more serious, more clinically oriented as a depression diagnosis as people progress into the later stages?
Yes, and most or all of the non-motor symptoms tend to get worse as the disease progresses. Speaking of which, and since we're talking about mood, I'd like also to add dementia as part of a symptom that we tend to see in more advanced stages. And with dementia, we also see hallucinations. So these is also an interesting symptom because hallucinations is a perception of an object or an animal, some kind of a visual hallucination.
I read it was visual, so you're not hearing things that you're worried about.
Not auditory.
But it's all what you imagine that you're seeing.
Most of the times it's visual, and most patients recognize that it's not real. What they're seeing is not real, and it usually starts with a sense of presence. They feel that there's something in the corner of their eye, and they kind of turn around to see who's there. Also, seeing insects or ants on walls or surfaces.
So that's just got to be an insult to injury, isn't it, to have to deal with that? That's very difficult.
It's very important that usually it's not bothersome to the patient or the caregiver. However, it becomes very severe then, and when the patient starts thinking that they're real, then it becomes a big problem and we need to treat.
And you would treat that with
psychotics, but not all of them, because most of the antipsychotics worsen Parkinson's symptoms, the motor symptoms. So there's only a few that we can use.
So it's very important if you're dealing with that to see a person who specializes in Parkinson's. Not the average internist, I'm guessing, would not be prepared to.
Well, that's why we need to increase awareness and
educate the internists
and the patients, and the patients need to recognize what their symptoms are and which ones are related to Parkinson's disease. It's not just the tremor, it's not just the slowness of movements, not the posture, it's more than that.
And it would be important, I think, too, I'm guessing, for patients and family members to say, you know, my loved one or myself, I'm not imagining these things. I'm not making these up. These are real. These go along with the disease, right?
Yes, that is very important.
The number of people who have Parkinson's who get to that stage where they have dementia, Dr. Vaou, do you have a number in your head that you could share?
How many patients get to that stage?
Percentage-wise, do most get to that?
So in advanced Parkinson's disease, we are usually talking about 80% reaching a stage where they will get dementia. So it's pretty common in advanced stage, yes.
We're talking about over a number of years, but
we're talking about 10 plus years.
10 plus years, okay. Well, we're out of time, and this has been fascinating, and as I shared with you, I think so important to understand all these accompanying symptoms. We want to give you a couple web pages, so if you would like to learn more, or if you would like to contact Dr. Vaou, The first website is www.apdaparkinsons.org, and that's the American Parkinson's Disease Association website. The phone number, national number, is 888-302-7762, or locally here in St. Paul, 651-241-8297. And then the Noran Neuruological Clinic here in Minneapolis, right on Chicago Avenue by Abbott Northwestern, noranclinic.com. And as I said, this is where Dr. Vaou practices. Well, we have 1 minute left. Is there one thing you would want to say to a viewer who's got Parkinson's, who's hearing all these symptoms?
Well, I'd like to say that, first of all, don't be discouraged by the diagnosis. There's a lot of research going on, a lot of hope. We have, like we said earlier, there's no cure, but there certainly is symptomatic treatment, and exercise is a very, very important way to improve their symptoms, along with medication, of course.
And something people have some control over.
Yes.
I think when your body's misbehaving, if you can control some of the things you do, that's great. Well, thank you so much.
You're
for
welcome.
coming
It was
down.
really nice being here.
Very nice
Thank
to
you.
work with you. And I hope your life here in Minneapolis is wonderful. She's lived in Greece, where she was born, studied in Hungary, New York City, Boston. So we're very lucky to have you here
I
in
love it
Minneapolis.
here. It's very nice. Yeah.
Thank you for being with us. We'll be back again next week. Until then, have a good week.